The cardiomyopathies. The cardiomyopathies are a heterogeneous group of entities affecting the myocardium primarily and not associated with the major causes of cardiac disease. Example: ischemic heart disease, hypertension, valvular disease, or congenital defects. While some have specific causes, many cases are idiopathic. There is now general agreement on the classification based upon general features of presentation and pathology. Three types. One is dilated cardiomyopathy, second one hypertrophic cardiomyopathy, and third one restrictive cardiomyopathy. We will see about the primary dilated cardiomyopathy. General considerations. Dilated cardiomyopathies usually present with symptoms and signs of congestive heart failure, most commonly dyspnea. Occasionally, symptomatic ventricular arrhythmias are the presenting event. Left ventricular dilatation and systolic dysfunction are essential for diagnosis. A growing number of cardiomyopathies due to genetic abnormalities are being recognized, but these still represent a small minority of cases. Often no cause can be identified, but chronic alcohol abuse and unrecognized myocarditis are probably frequent causes. Amyloidosis, sarcoidosis, hemochromatosis, and diabetes all may present as dilated cardiomyopathies as well as with a restrictive picture. Histologically, the picture is one of extensive fibrosis unless a specific diagnosis is established. Causes are idiopathic, alcoholic, myocarditis, postpartum, doxorubicin, endocrinopathies, and genetic disease. Clinical findings, signs and symptoms. In most patients, symptoms of heart failure develop gradually. They may be recognized because of asymptomatic cardiomegaly or electrocardiographic abnormalities, including arrhythmias. The initial presentation may be severe biventricular failure. The physical examination reveals cardiomegaly, S3 gallop rhythm, and often a murmur of functional mitral regurgitation. Signs of left and right-sided failure may be present on initial examination, a clue to a process involving the heart difficulty. Left or biventricular congestive heart failure is a symptom. Electrocardiography and chest X-ray. ST and T changes, conduction abnormalities, ventricular ectopy will be present. In chest X-ray, enlarged heart, pulmonary congestion will be present. Diagnostic studies. An echocardiogram is indicated to exclude unsuspected valvular or other lesions and confirm the presence of dilated cardiomyopathy. Exercise thallium-201 scintigraphy may suggest the possibility of underlying coronary disease if a large reversible defect is found, but false positives occur in cardiomyopathy. Cardiac catheterization is seldom of specific value unless myocardial ischemia or left ventricular aneurysm is suspected. The serum ferritin is an adequate screening study for hemochromatosis. In cardiac catheterization, left ventricular dilation and dysfunction will be present, high diastolic pressures and low cardiac output. Treatment. Few cases of cardiomyopathy are amenable to specific therapy. Alcohol use should be discontinued. There is often marked recovery of cardiac function following a period of abstinence in alcoholic cardiomyopathy. Endocrine causes thyroid dysfunction, acromegaly, pheochromocytoma should be treated. Immunosuppressive therapy is not indicated in chronic dilated cardiomyopathy. The management of congestive heart failure is outlined in the section of heart failure. Prognosis. The prognosis of dilated cardiomyopathy without clinical heart failure is variable. with some patients remaining stable, some deteriorating gradually, and others declining rapidly. Once heart failure is manifest, the natural history is similar to that of other causes of heart failure. Arterial and pulmonary emboli are more common in dilated cardiomyopathy than in ischemic cardiomyopathy. Suitable candidates may benefit from chronic anticoagulation. Those patients whose disease progress may require treatment for severe dyspnea and ultimately need high quality palliative care. Thank you.